Bundled care programs are a key driver in the transition from fee-for-service to value-based care. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hederle with AHA Communications. In this Members in Action podcast featuring maternal and child health efforts, Aisha Syeda, Senior Program Manager at the AHA, is speaking with CJ Stimson, Chief Medical Officer for the Vanderbilt University Medical Employees Health Plan and Senior Vice President of Value Transformation in the Office of Population Health. Together, they will discuss how Vanderbilt University Medical Center is working with Metro Nashville Public Schools to provide bundled care solutions, which improve maternal health outcomes and provide more value to patients and payers.
Thank you, Tom, and thank you, Dr. Stimson, for speaking with me today. To start us off, can you give us some background about why Vanderbilt University Medical Center felt the need to invest in a provider-led bundled care program for maternity care?
Happy to, Aisha. And first, just let me say thank you for inviting me on behalf of our team here at VUMC to share our story. We're very proud of what we've done here with maternity care, and I would like to spread that word around, so thank you. So your question, why a bundle program for maternity care? Well, for us, it didn't actually start with maternity. We kind of got into this idea of bundled payments and value-based care. Where we were coming at it from was we really felt like there was misalignment in the system from the traditional fee-for-service payment model. And that misalignment was really putting what was clinically appropriate for patients oftentimes at odds with what was financially rewarding for providers, hospitals, physicians. And that misalignment between what's the right thing to do clinically and what may be the right thing to do financially, that was really creating a bad experience for patients, bad for their clinical outcomes, bad for their financial outcomes, bad for their service experience and their experience on the whole. And so when we created our bundled program, we said we're going to scrap the old payment model that just rewards doing more, doesn't reward doing better. And we're going to come with a new payment model that rewards ourselves for doing what's right for patients, for delivering a much better care experience. And so that was the whole mission for our work, was we want to use these value-based payment arrangements to deliver a better outcome and experience for patients. But we didn't know exactly where to start. And this is where the maternity enters the picture, because we've had extensive experience in Medicare. I spent a lot of time in Medicare myself. And so we knew that there were value opportunities inside musculoskeletal care, for example. So total hip, total knee replacement, spine surgery, osteoarthritis, others. But what we did is, instead of starting in those places, we first went to the purchasers of healthcare, the employers in our market. And we said, hey, we're wanting to bring this program to the market where we're going to use value-based arrangements to deliver a better care experience. But where do we start? If we're going to focus on doing direct contracts with large employers, what are those large employers interested in? What problems can we solve for them? And so we went and talked to one of our long-standing partners, Metro Nashville Public School Systems, and a really inspirational leader they have there, a guy named David Hines. And we said, David, here's the program. Here's what we're trying to do. Where should we direct our energy? What problem can we solve? And I thought for sure he was going to say something musculoskeletal, but he said, my problem is in maternity. He said, I need you to solve that problem for me. And so that is the reason that we dove into maternity, is because we listened to the marketplace, and the marketplace was clear, is that his high-cost claimants were overwhelmingly coming out of the neonatal intensive care unit, the NICU, and that his variability and unpredictability in spend, he thought, was coming out of C-section rates and other areas of variation that exist in the maternity experience. And so his thesis was, well, if I can get a provider to engage in a value-based arrangement on maternity, then I can address some of these issues that I think I'm having in spend, C-section rate, NICU, and so forth. And so that was really the genesis of the program. And I think we are so lucky that we had someone like David out there at the school district to guide us, because we weren't going to go there first. And we've had tremendous success because we did go there first, and we've been able to expand to other areas because of the success of the maternity program. So it really comes down to, we did maternity because we had a mission that we wanted to chase, but we needed someone to give us direction. And it was the school system that said, this is where the problem is, help us.
Thank you for sharing that background. It's really helpful to know. So can you talk a little bit about how the program works and what's the ultimate goal?
Sure. So the goal of the program, I'd like to start there, kind of start with the why. The goal of our program is to deliver, no pun intended, but to deliver the best maternity care experience that a mother can have. And we mean that not just in kind of the traditional provider-centric way, like myself, I'm a surgeon. You know, I think of clinical outcomes as the definition of a great care experience, but there are others. And so we want people to have a great clinical outcome, but we want them to have a great financial outcome personally for themselves. And we want them to have a great service experience. And so those things are really what we're chasing after and our ultimate goal. And the way the program works to help us be successful in those things, it is a prospective bundled payment arrangement that exists on a direct-to-employer or a direct-to-provider contract, however we like to think about it. So what that really means is, for those who may not be familiar with bundled payments, what we've done is we've set a single prospective price that includes all of the services that are part of a full maternity experience for a newly pregnant woman. So in real terms, that means, you know, starting with that very first prenatal visit, you know, confirmation of pregnancy, until all the way through 3 months after delivery, every service that that woman needs to ensure that she has that great experience is included. And so that's the professional services from the physicians and the providers. It's all of the facility related services. It's services that traditionally don't get billed for or paid separately. So classes, lactation support. We even include in the price, you know, if a pregnant woman requires an emergency department visit or has a inpatient admission that's related to her pregnancy, all of those services are included at a single price. And we went a step further and we said, let's make it a single price irrespective of how the delivery occurs. So one price, doesn't matter if it's a C-section or a vaginal delivery, it's included. And so what that means for us is that we not only take risk on all of those services that I just described that are included in what is effectively about a year-long bundle, give or take the timing of delivery, but we also take risk on our C-section rate. And we think that's pretty important. We think it's also probably pretty rare. But what it does is, going back to those first principles, is it aligns what is good for patients, which is to have only those C-sections that are absolutely necessary, with what is good financially for the system, which is to do fewer C-sections. And so the better we can do for our patients, the better we can do for ourselves financially. And I think that's the magic of what we've done here, is we've created a very comprehensive program that includes all those services, and then we've aligned the payment model or the financial model to support that great clinical program.
There is just that one fixed price regardless of how you deliver. That's wonderful. Can you speak to some of the outcomes you've seen since this program has been implemented?
Certainly. So we classify the outcomes in our program into three groups. There are clinical outcomes, financial outcomes, and service outcomes. So clinically, we're tracking a lot of metrics. Some you can imagine are very important to us is our C-section rate. And so what we've seen in our bundled population is that the C-section rate for those patients is about 25% less than what is seen in the marketplace. And so already we're delivering significant clinical value that way by having a much lower C-section rate than the marketplace. We also look at things like early elective deliveries. 0% of our patients undergo early elective delivery. There is a special C-section rate that is for those first-time moms whose babies' heads are in the down position and are just really set up well to not have a C-section. We monitor that very specific C-section rate, and ours is significantly better than benchmark in the marketplace. And so we monitor kind of a variety of these clinical indices of good care and have found that our outcomes are outstanding, particularly around that C-section rate. We're very proud of that. Financially, we look to see, okay, well, what is the spending savings for not just the employer who's, engaged in this direct-to-employer contract, but also for the employees who are in this program. And what we found is that because of the structure of this program, the school district is able to bring the program at zero out of pocket for the entire maternity experience to their employees. And so it's essentially, the way they market it is and they'll say this, I've heard them say this, is you can have your baby at no charge, which is about a $2,500 savings per member for the school system's health plan. So $2,500 back in their pocket. And if you look at all of the savings for the school district over the first year, it's around $400,000 that we've saved them and their employees on their maternity spend. And what's really exciting, and this is just kind of late breaking news, is that we've seen the NICU spend for the school district in these bundled populations compared to their non-bundled populations go down about 16% in the first year. And so that's very exciting because that was one of the original problems we're trying to solve. So seeing really good results there. And then from a service standpoint, we track Net Promoter Score very closely. Now, Net Promoter Score was a new concept to me, 3 or 4 years ago when we first started this program. I've since come to live and die by Net Promoter Score. It's all I think about in my spare moments. But for those who don't know, Net Promoter Score is that single question that you've answered many times in different surveys that says, on a scale of 0 to 10, how likely are you to recommend this product or service to a friend or a family member? And then based on where you fall on that scale, there's a calculation that occurs, and that spits out a Net Promoter Score. It can be anywhere between negative 100 and 100. And in healthcare, Net Promoter Scores are usually in the high 20s. You can think about a company like Amazon in the 60s, Starbucks in the 70s, maybe the low 80s, Tesla in the 90s. It's really hard to get a high score for Net Promoter Score. And what we've seen is that through our first 2.5 years, our Net Promoter Score is 88, which is just exceptional. And what that says to us, and what we've seen in the written feedback and the personal conversations our patient navigators have with all these bundle patients, is that they're having an outstanding experience and really pleased with their experience at Vanderbilt in the maternity bundle. And we think that's the reason that we continue to see such growth in our program year over year, We started in the first year, I think we enrolled between two employers around 600 patients. The next year it was over 750 patients in this program. And then we're on track to be close to 1,000 in the third year of this program. And so we feel like across those three domains, the clinical, the financial, and the service, we've really just had some exceptional outcomes that we're very proud of.
That's so great, and I love that you're collecting these metrics in those three buckets. What have been some lessons learned? Are there any challenges in this work, or any surprises during the process?
I love this question. I get this question all the time. I'll start with the hard stuff. I think the challenge that I did not predict was on what I call the back side of the house, the billing side of the house, the rev cycle, the financial side. When we are engaging in value-based relationships directly with employers, we are having to run those contracts on kind of the legacy fee-for-service system on top of that. We're having to rework quite a bit to make that seamless for ourselves and for the school system or all the other employers that we're working with. And so that's been tough. And part of that was that I didn't, as a surgeon, I didn't have a lot of experience in rev cycle. Now I know way too much, but that's been challenging. And we've had to go to outside partners to get help with that. And that's worked. But for anyone who's considering this, I think you cannot underestimate just how much work it's going to be required to get the billing part of this right. But it is doable. And I think you just have to go in with your eyes open. Moving to kind of the pleasant surprises, we were told on our team that the most difficult part of this was going to be getting providers on board, particularly physicians, advanced practice practitioners. In our case, we include certified nurse midwives, that those folks would not be interested in engaging in risk-based arrangements. They wouldn't want to take on risk. And what we found was actually the complete opposite. I think we underestimate how burdensome the legacy fee-for-service system can feel for providers. I can tell you myself, I feel that in my practice. And so when we show up to a room of obstetricians and we say, throw away all your preconceived notions about how you get paid and just come up with what you think is the best experience that one of your pregnant patients can have. What would you do for them? How would you do it? When would you do it? And build that delivery model, build that ideal state. And we will come in and build the payment model that surrounds it and supports it. And if you're willing to take a bet on yourself, which is really what taking risk is all about, if you're willing to take a bet on yourself and your ability to meet that ideal state that you created, then we can build this thing. We can build this ideal state that you've imagined. We can make it a reality. And when you talk about value like that, not as about a competition over dollars or, what's my benchmark or am I being compared against the right group? When you talk about it in an aspirational way, about how you can create something exceptional for the people you take care of every day, everyone's hand shoots up. They all want to be a part of it. And that's been our experience, not just in maternity, but in the 8 other bundle programs that we've since built and have launched with all these employers. I think that providers are hungry for this. They're willing to take on risk if it's built the right way, if their fingerprints are on it. And that's where we've had a lot of success. I'd add one more pleasant surprise, only because I just recently met with our patient navigator group. So something we've brought to our bundle patients that we weren't doing before is that every single bundle patient gets their own patient navigator. We think of this kind of as a concierge light. It's not a clinical individual. These are folks who their job is to make sure that our bundle patients have that exceptional experience that I talked about. when they're trying to navigate the system. So if they're having a hard time scheduling appointments, or if they have billing concerns, or maybe they just need to talk through something difficult in their care, and they actually do that. They will call these navigators weekly at times to just run through things about their care. When we created the patient navigator role and made that kind of the linchpin of the program, I did not anticipate how patients would see them as so integral to their experience, truly a member of the care team. I really didn't see that coming. But now what I've seen after, almost 3,000 patients enrolled in this program, that is exactly what's happening. The patients, in the same way the providers were kind of hungry to build their own ideal state and bet on themselves, the patients have this pent-up demand for someone who can be at their elbow and walk along next to them during this journey to make it easier on them. And I think our patient navigators are an exceptional team, and they've delivered on that promise. And it's been one of the most exciting things that I've witnessed in the program.
Thank you for sharing that. And I think we've heard from other hospitals that have used patient navigators that they've seen the same response, that patients like the aspect of having somebody close by that can support them throughout their journey. So I think it's wonderful that you've incorporated that into this program as well. So my last question to you is, what's next? How will you keep this work moving forward? What's in the works?
For us, it's all about growth. And that may not be in the traditional strategic swim lane that you think of growth. I'll just say that, we're a very large health system, 30,000 employees, 5 or 6 different hospitals spread across a very wide geography. And we want to grow our maternity within that system. But the reality is we can't deliver every baby in the state of Tennessee. We can't deliver every baby in Middle Tennessee. We don't have the capacity to do that, nor do we aspire to create that. When I say growth, what I mean is we want to spread the story of what we've done and the success that we've had across our market, across Tennessee, because we think this is the right way for pregnant women to be taken care of, period. And we can't do it all ourselves, and we want to help other health systems and purchasers of healthcare experience what we've experienced. Because there is a problem in maternity care. We think it's a misalignment between the payment model and the clinical model, and we think we've solved it. And so when I say growth is our next step, what I mean is I would love to see every health system in Tennessee have a bundle program just like ours to help take care of these patients so that they can have the type of experience that our bundle patients have. Tennessee, in the South, nationally, because we've done a lot of the hard work to build it, and we want to see it grow. And not just to, fill our own hospital. Like I said, we can't do all of that, but just because we need to do a better job for these patients. And so I think for me and for our team, that type of growth is what we're most excited about.
Thank you so much, Dr. Stimson, for sharing all the great work you're doing to improve outcomes for mothers in your served community. And hopefully this program will grow beyond VUMC. For more resources, visit AJ's Better Health for Mothers and Babies webpage. And thank you for listening.